Hi everyone, my name's Sam Heilbroner. I'm a physician and data scientist at Concerto Health AI. Today, I'd like to tell you about one of our exciting special projects predicting cardiac events in patients taking PD-L1 therapy. Before we begin, a few disclaimers. The results presented here are based on an abstract to be published at ASCO this May. Since we submitted the abstract, our methodology has advanced. We wanted to share with you the most up-to-date findings. These findings are still preliminary, and some of the results may vary slightly from what's been published so far. Our study has several limitations. Like most real-world data analyses, we rely heavily on ICD codes to represent disease status. However, in general, these codes do not always represent the ground truth, and further work is needed to validate the codes we used here. Our study analyzes the rate of adverse events. Like any adverse event analysis, one needs to consider the competing risk in the model. Sub-distribution models are generally considered more predictive, but cause-specific hazard models are often used when attempting to determine the drivers of risk. We opted for the latter approach. Like a differential diagnosis in medicine, our findings often have multiple interpretations. We present our best guesses here, but there are alternatives. Finally, we calculated p-values for our SHAP scores. This technique is still experimental and final results may change. Let's get started. What problem are we trying to solve? PD-1 and PD-L1 immunotherapy have improved oncology care across multiple disease states. However, these drugs have also been associated with serious immune-related cardiac adverse events, including the inflammatory condition myocarditis. While some of these conditions are rare, occurring in just 1% of cases, their mortality can exceed 30% according to some sources. We wanted to create a model to predict serious cardiac events in patients initiating PD-L1 therapy. In general, you can imagine that a patient's risk of cardiac disease is secondary not only to the side effects of therapy, but also to the burden of the tumor in organs like the lung. A therapy's potential to reduce tumor burden may outweigh the risk of side effects when it comes to cardiac risk. Cardiac history may also play a role. Conditions like congestive heart failure or a history of smoking may increase your risk. So in addition to asking, can we predict these serious cardiac events, we also want to ask which of these features are the major drivers of risk. How did we answer these questions? One challenge we faced almost immediately is that serious cardiac events, the kind that kill you, are rare. To maximize the power of our study, we used a transfer learning approach in which we trained the model on not only PD-L1 patients, but anyone who may have been a candidate for this therapy. In this case, all advanced and metastatic non-small cell lung cancer, renal cell carcinoma, and melanoma patients. PD-L1 therapy was included as a feature in the model. But at the end of the day, we only care about those PD-L1 patients. Therefore, the metrics, interpretations using SHAP scores, and predictions were conducted only on this PD-L1 subcohort. In any time-to-event analysis, you need to consider censoring. Traditionally, this is addressed using a Cox proportional hazards model. But in this case, we wanted to evaluate over 400 possible risk factors for cardiac disease. This is just too many for this traditional statistical technique. Instead, we took a hybrid approach, combining the power of the machine learning-based technique XGBoost with a CoxPH custom loss function, allowing us to get the best of both worlds. So how did our model actually perform? Generally, we would like to ask how accurately our model predicted cardiac events. But this is a time-to-event model. Cardiac events within how many days? 40 days, 60, 100? In general, we can vary this cutoff and see how it affects our results. The result of this analysis is shown on the upper right. You can see that no matter what cutoff we use, the model performs well with an AUC-ROC of between 75 and 85%. The model performed about equally well on PD-L1 patients and all patients, suggesting that our transfer learning methodology worked. How does this translate into actual predictions? We can split patients into a high-risk and low-risk group based on the model's projected risk. Cumulative incidence plots of these two groups are shown on the right. At 100 days, the high-risk patients were approximately 5 times as likely to have a serious cardiac event as the low-risk group. So our predictions are making a real difference. What is driving a patient's risk? We can use SHAP scores to interpret the model. SHAP scores are shown on the right if you can read them. If not, a summary is shown on the left. In general, we can see that a combination of oncologic, immunologic, and cardiac factors contributed to risk. For cardiac risk factors, a history of congestive heart failure, elevated respiratory rate, and elevated heart rate all increased risk, as did an elevated PT, which may suggest that the patient was on anticoagulation. The most obvious immunologic factors were the percent neutrophil and percent lymphocyte counts. We found that a high percent lymphocyte count and low percent neutrophil count decreased risk. In the literature, this pattern of lymphocytes and neutrophils generally increases your chance of responding to PD-L1 therapy, but also increases your risk of getting side effects from that therapy. This may suggest that cardiac risk is reduced more by the benefits of responding by therapy than it is increased by the risk of side effects. Finally, low weight and BMI increase cardiac risk, and these are two obvious oncologic factors that may be driving a patient's propensity for cardiac events. So what have we learned? The Concerto data gave us a large number of patients with over 400 features for analysis. Many more are available. Combining this data with the most advanced machine learning techniques, we can drive meaningful insights in oncology. In terms of methods, transfer learning was an effective tool for studying a rare problem. With a custom loss function, we could combine the rigor of traditional statistic with the power of predictive ML. This strategy led to good performance. In terms of cardiac risk, what we actually learned: cardiac features like heart failure, immunologic features like the percent lymphocyte count, and oncologic features all played a role in predicting a patient's risk of cardiac events. Thank you.